So for over half a century, doctors have essentially used this very specific invisible stopwatch to figure out if a woman's labor was considered normal.
Right. The whole textbook timeline.
Exactly. And if she took too long or, if she didn't hit certain milestones on that exact schedule, the medical team would intervene.
Usually with surgery. Yeah.
Yeah. But what if I told you that stopwatch was completely wrong? Like, what if it was based on women from 50 years ago whose bodies and demographics were entirely different from mothers today?
It's wild to think about. I mean, just the sheer number of unnecessary surgical interventions, C-sections, that might have happened simply because we were comparing modern women against this completely outdated timeline.
It really is. It fundamentally changes how you view the entire medical process.
Yeah.
And that is exactly why we're doing this custom tailored deep dive for you today.
Yeah, it's going to be a good one.
Because whether you are planning a family or supporting a partner or, you're just insanely curious about what the human body is actually capable of, this is really going to shift your perspective.
Totally.
We're pulling from a pretty comprehensive, evidence-based medical bedrock today. It's called nursing care of the family during labor and birth.
Which is such a brilliant foundation, honestly, because it bridges that massive gap between raw biological physiology and the actual, art of nursing care.
Right.
It really shows how the body and the mind just have to cooperate.
Okay, let's unpack this, because our mission today is to completely decode the modern birthing process. We are moving way beyond those Hollywood cliches of a woman screaming, a doctor yelling push, and then a perfectly clean baby just magically appearing 2 minutes later.
Yeah, the movies definitely lie to us on that one.
They really do. We're going to uncover the raw physics, the critical psychology, and the minute-by-minute care that guides a birthing person through this absolute marathon.
From the very first pangs all the way to the end.
Exactly, all the way through that critical golden hour after the baby arrives. And I mean, it starts with that stopwatch we just mentioned, because figuring out when labor has actually begun is notoriously difficult.
Oh, it is. Especially for first-time mothers.
Yeah.
And part of the reason it's so confusing is that the medical definition of active labor had to be, well, completely rewritten.
Right, because of that old timeline.
Yeah, the E.A. Friedman timeline. For decades, the medical field just relied on his research. But when researchers finally went back and studied thousands of contemporary women, they realized the baseline had entirely
The
shifted.
demographics, right?
Exactly. Today's birthing population tends to be older and heavier than their counterparts from 50 years ago. So because of this, their bodies just naturally take longer to labor, and they progress a lot more slowly.
So for decades, active labor was strictly defined as starting at 4 centimeters of cervical dilation. But the modern evidence-based consensus is that active labor doesn't actually begin until 6 centimeters.
Which is a huge difference.
It is. I mean, 2 centimeters might not sound like a huge leap to someone outside the delivery room, but changing that baseline from 4 to 6 centimeters, that is a 50% increase in what we basically consider the warm-up phase.
Right. It completely redefines when medical professionals step in.
Exactly. It forces everyone to pump the brakes and just stops them from rushing a physiological process that naturally just takes longer now.
And what's fascinating here is that even before you get anywhere near that 6 centimeter mark, you have to navigate this incredibly frustrating phenomenon of false labor.
Oh man, false labor.
Yeah, so a pregnant woman might feel these strong, highly regular contractions. She rushes to the hospital, completely convinced the baby is coming, only to be told she isn't in true labor.
Because her cervix isn't actually dilating.
Exactly. And it leaves patients feeling angry, discouraged, and honestly just questioning their own sanity.
Is false labor basically the body's way of practicing the emergency evacuation route before the actual alarm goes off? Like, it feels incredibly real, but it's just a systems check.
That is a perfect way to look at it. The body is doing physical work. It's just not doing the specific work of rapid cervical dilation yet.
Right.
And if you know what to look for, there are physiological tells to differentiate the two. True labor contractions actually become more intense if you get up and walk around.
Oh, so movement accelerates.
Yes, the physical movement accelerates the process.
Yeah.
And that pain is usually felt deep in the lower back, radiating around to the lower abdomen.
And false labor.
False labor contractions are different. They're often irregular. If you change your position or, if you get up and walk, they might actually stop entirely.
Wow.
And the discomfort is usually felt much higher up in the abdomen, like above the belly button.
So imagine you're terrified, you're in pain, you show up at the hospital with these false alarms, or maybe you're just in very, very early labor. The standard medical advice used to be to just send you back home.
which is awful.
That sounds incredibly anxiety-inducing. But I love this innovation we found in the research, the early labor lounge.
It's such a brilliant, empathetic middle ground, isn't it?
Yeah.
It's a dedicated room in the hospital specifically for women who aren't quite dilated enough to be officially admitted, but who feel too vulnerable to just leave.
So they can stay on site as outpatients?
Exactly. They can walk the halls, rest, use acupressure, or just have the psychological peace of mind that medical staff are right down the hall.
And there is a massive legal and ethical safety net underpinning all of this, too. A federal regulation called EMTALA.
Yes, the Emergency Medical Treatment and Active Labor Act. If you interact with the American healthcare system, you really need to understand this.
It's huge.
Under EMPALA, any pregnant woman who presents at a hospital with contractions is legally presumed to be in true active labor until a qualified healthcare provider physically assesses her and certifies that she is not.
Wow.
Yeah, she must be evaluated and stabilized, regardless of her insurance status or her ability to pay.
Which ensures that the physical safety of the mother and the baby is the absolute baseline. No one gets turned away at the door just because of paperwork.
Right, absolutely.
But here's the thing. Understanding that physical timeline, the centimeters, the vital signs, that's really only half the story. The physical dilation of the cervix is heavily, heavily influenced by the birthing person's psychological state and their cultural background.
Oh, definitely.
We always think of medical care as purely biological, right?
Wow.
Measuring heart rates, drawing blood. But looking at the evidence, it sounds like a labor nurse's primary tool is actually intense emotional intelligence and on-the-fly cultural translation.
If we connect this to the bigger picture, the birthing room is basically a microcosm of a person's entire life experience.
Yeah.
How a woman reacts to the sheer pain and stress of labor is inextricably linked to her social, cultural, and psychological history. And one of the most vital aspects of modern care is providing trauma-informed care, particularly for survivors of sexual abuse.
The clinical guidance is incredibly direct about this, actually. It points out that the highly intrusive procedures of labor, like frequent vaginal exams, can easily trigger memories of sexual assault. And because a nurse usually doesn't know who is a survivor and who isn't, the standard is a universal approach of deep, respectful care for everyone. Always asking permission before touching.
Keeping a consistent care team, too.
Yes, preferably female, rather than a rotating cast of medical students coming in and out of the room.
And it filters all the way down to the exact vocabulary used in the delivery room. Caregivers have to be trained to avoid phrases that could echo the words of an abuser.
Like what?
Directives that used to be common, like open your legs or relax and it won't hurt so much,
Yeah.
those can be deeply traumatic and cause a complete psychological shutdown.
That requires a complete shift in how medicine is practiced.
It really does. Trauma-informed care shifts the entire medical paradigm. Instead of walking in and asking, "What is wrong with you?" the provider asks, "How can I help you feel supported?"
Which is such a better question.
It is. And there is a raw biological reason for this. When a birthing person feels unsafe, their body pumps out adrenaline.
The fight or flight hormone.
Exactly.
Yeah.
And that literally restricts blood flow to the uterus, shunting it to the limbs, which halts labor. But when a patient feels safe, their anxiety drops, adrenaline fades, and oxytocin, the hormone that drives labor, just takes over.
So psychological safety is a literal physiological catalyst for birth.
Yes, absolutely.
And the way that safety and pain are expressed is completely bound by culture, too. The research notes that in some cultures, a laboring woman is expected to be entirely stoic, not making a sound.
Right.
In others, vocal moaning and loudly crying out are the absolute norm.
Which means a nurse cannot assess a patient's pain based purely on volume.
That makes sense.
Yeah, a woman who is completely silent but clenching her jaw might actually be experiencing far more severe physical pain than a woman in the next room who is crying out loudly.
Oh, wow.
And if the care team misinterprets that silence as a lack of pain, they are failing to provide adequate medical care.
This cultural competence extends right through to the end of the birth, too, even involving what happens to the placenta.
Oh yeah, the placenta.
Yeah, for instance, in many Spanish cultures, the placenta is sometimes called a compañera, which translates to the companion of the child.
That's beautiful.
It is. Families may request to take it home for specific burial rituals, believing it protects the newborn from bad luck. A culturally sensitive hospital has to have policies to safely honor that rather than just, throwing it in a biohazard bin.
Exactly. And to navigate all of this, the trauma, the cultural translation, the intense physical pain, The evidence heavily emphasizes the impact of continuous labor support.
Like having a doula.
Yes, having someone like a doula in the room. And the statistics on this are just staggering.
But why is that? I mean, it's nice to have someone holding your hand, but how does a doula actually change the medical outcome?
Well, it goes right back to that hormonal mechanism we just discussed.
Mhm.
Having continuous emotional and physical support from someone whose sole focus is the laboring woman, not the medical monitors, not the clinical charting, it keeps that adrenaline at bay.
So it keeps the oxytocin flowing?
Yes. Because of that hormonal shift, statistics show a doula significantly decreases the use of epidural anesthesia. It lowers the likelihood of needing a cesarean birth.
That's amazing.
It's even linked to better APGAR scores for the baby. You know, that crucial first test right after birth, checking the newborn's breathing, heart rate, and reflexes.
Because a calm mind allows the physical body to do the mechanical work it needs to do.
Exactly.
So once you have that calm environment and the cervix is finally open to 10 centimeters, the rules of the game completely change. You shift from a psychological waiting game to pure, raw physics.
Gravity takes over.
Gravity takes over. It is time to bring the baby into the world.
And the second stage of labor is where modern evidence-based practices are really challenging standard hospital protocols.
I found this part so counterintuitive. When you picture a hospital birth, you almost always picture a woman confined to a bed, lying on her back, feet in stirrups.
Like in every movie ever.
Yes. But the physical evidence explicitly states that upright positions, squatting, standing, hands and knees, actually shorten labor. They use gravity to pull the baby down, and they physically, mechanically widen the diameters of the pelvic bones.
Which is what you want.
Right. So wait, if the medical technology designed to monitor the baby is actually what's trapping the mother in a position that prolongs labor that feels incredibly backward, why are they still in bed?
Well, it's a cascade of medical interventions. Confinement to bed is largely the result of the epidural.
Oh, because they can't feel their legs.
Right. An epidural numbs the lower half of the body, which severely limits a woman's motor control and leg strength, meaning she cannot safely stand or squat.
That makes sense.
You combine that with the cords from continuous electronic fetal monitors and IV lines, and the medical technology literally tethers the patient to the mattress.
But even if a woman has an epidural and has to remain in bed, there are physical tools to help mimic those upright physics, right? The peanut ball is a great example.
Oh, the peanut ball. It's a fantastic, remarkably simple intervention. It's just a large exercise ball, shaped exactly like a giant peanut.
Right.
It is placed between the legs of a woman who is laboring in bed with an epidural. And by keeping her legs separated and her pelvis open, it mechanically mimics the pelvic widening of a squat, even while she is lying down.
That's so clever.
It really is. Studies show that using a peanut ball can significantly reduce the time spent pushing and lower the need for a C-section.
It's amazing that a giant foam peanut can rival high-tech medical interventions.
Right.
And when it comes to the actual act of pushing, the body has an automatic override system. It's called the Ferguson reflex.
This is a powerful physiological response.
Whoa.
As the baby descends, the presenting part, usually the head, presses on stretch receptors deep in the mother's pelvic floor.
Okay.
This mechanical stretching sends a signal directly to the brain, triggering a massive surge of oxytocin. This creates an overwhelming, completely uncontrollable urge to bear down. It is the body entirely taking over the process.
And how a woman pushes when that urge hits is another area where the movies get it completely wrong.
Oh, totally.
In the movies, the doctor always yells, take a deep breath, hold it, and push for 10 seconds. But the research says that is actually dangerous. If holding your breath spikes your blood pressure and starves the baby of oxygen, why on earth is that the default? Is there a safer way to do it?
This raises an important question about how much the medical establishment trusts the physiological process. What you're describing from the movies is called closed glottis pushing, or the Valsalva maneuver.
The Valsalva maneuver, okay.
The woman holds her breath, closes her airway, and bears down forcefully on command. But doing that increases intrathoracic pressure. It reduces cardiac output, which decreases the flow of oxygen to the fetus.
It's like trying to squeeze out the last bit of toothpaste from a tube by just squeezing the middle as hard as you can, instead of steadily and gradually rolling it from the bottom.
Precisely. The safer evidence-based alternative is open glottis pushing.
Which means breathing.
Exactly. When women listen to their own bodies instead of arbitrary counting from the staff, they instinctively push while exhaling. They leave their airway open, often making grunting or panting sounds.
Okay, so making noise is actually good.
Yes. It aligns with their natural urges, it prevents that dangerous spike in blood pressure, and it allows the tissues to stretch gradually, which reduces severe tearing. Major medical organizations now endorse letting the woman choose the pushing technique she prefers.
So she listens to her body, she pushes with an open glottis, the baby emerges, and you would think the marathon is over. The climax of the movie has happened, the music swells. But physiologically, the process immediately enters its most critical, high-stakes final stages.
Yes, the baby is born, but the placenta, the organ that fed the baby for 9 months, is still attached to the inside of the uterine wall. The third stage of labor is the delivery of that placenta.
So, what does this all mean? It seems like the moment the baby is out, everyone in the room probably exhales and relaxes. They're looking at the newborn. But physiologically, isn't the mother's body actually performing its most high-stakes magic trick right in that moment? Shrinking the uterus instantly to stop her from bleeding out.
It is an incredibly vulnerable moment. Postpartum hemorrhage is the major cause of maternal death worldwide.
Wow.
Think about it. When the placenta detaches, it leaves a large open wound on the inside of the uterus, about the size of a dinner plate.
A dinner plate? That's terrifying.
It is. The only way to stop that bleeding is for the uterine muscle to clamp down hard and fast, acting as its own internal tourniquet.
And doctors don't just wait around to see if the body will do this on its own anymore, right? There's been a major shift toward AMTSL active management of the third stage of labor.
Right. Instead of passive management, where you just wait for the placenta to detach spontaneously, AMTSL involves giving the mother a preventative or prophylactic dose of oxytocin immediately after the baby is born.
So they give her the hormone.
Yes. Then, the care provider applies controlled traction to the umbilical cord to help pull the placenta out quickly. This active management significantly shortens the third stage and drastically decreases the risk of dangerous hemorrhage.
But before they pull on that cord, there is a crucial pause that completely benefits the baby. It's called delayed cord clamping. They wait 30 to 60 seconds before clamping and cutting the umbilical cord. It's basically like leaving a phone plugged into a battery just a little bit longer to get that final charge.
That's a great analogy. That brief delay allows for a physiological transfer of blood from the placenta into the newborn.
Which does what for the baby?
It gives the baby a critical boost, increasing their hemoglobin levels and their iron stores for the first several months of life. It's a simple 30-second pause with lifelong benefits.
And while that pause is happening, the unwrapped baby goes directly onto the mother's bare chest for immediate skin-to-skin contact. This isn't just about emotional bonding or getting a cute photo for Instagram, right? It is a literal clinical intervention.
Far from it being just for photos. Placing the newborn on the mother's chest physically stabilizes the baby's cardiorespiratory system.
Wow.
Yeah, it regulates their erratic heart rate, smooths out their breathing, and helps maintain their body temperature. It even results in higher, more stable blood glucose levels for the infant in those chaotic first few hours of life.
The golden hour is literally a symphony of biological adjustments. Even things that look terrifying to a new parent are part of the orchestration, like the baby's hands and feet looking blue or dusky right after birth.
Oh, nurses frequently have to reassure panicked parents that this is totally normal.
Circulation, right?
Exactly. The newborn circulation is still establishing itself outside the womb. The body is smartly shunting the oxygenated blood to the vital organs in the brain, the heart, the lungs, before worrying about the toes.
And while the parents are staring at those tiny blue toes, the nurse is meticulously monitoring the mother in the fourth stage of labor, the first 1 to 2 hours of recovery. They frequently perform what's called a fundal massage, pressing firmly on the mother's abdomen to check the uterus. They need it to feel firm and globular, like a hard grapefruit. If it feels boggy, like a soft, squishy water balloon, it means the muscle isn't clamping down and dangerous blood clots could be forming.
It is a profound, delicate balance. The nurse is facilitating this beautiful, quiet family bonding while simultaneously keeping a hyper-vigilant watch for any signs of physical instability.
It's just incredible. To you, the listener, whether you are preparing for your own labor, supporting someone who is, or just wanted to understand the absolute extremes of human survival, I hope this deep dive shifts how you view this entire process.
Because it's not just a medical event.
No, birth isn't just a medical emergency waiting to happen that needs to be managed by machines. It is a profound, innate, brilliantly orchestrated human capacity.
It is a dynamic, minute-by-minute collaboration between the birthing person's psychology, their cultural grounding, their raw physical physiology, and the targeted, evidence-based care of their medical team.
Here's where it gets really interesting, though. We've talked so much about when to clamp the cord and the active management of delivering the placenta. But there is a practice called lotus birth.
Oh, yes.
In a lotus birth, the umbilical cord is never clamped or cut at all. The placenta is delivered and simply stays attached to the baby for several days until the cord naturally dries up and separates on its own.
Which sounds pretty wild to most people.
It is a jarring concept for those of us used to the hyper-efficiency of a hospital. But I want to leave you with this thought to mull over. In our modern, fast-paced world of medical intervention, when you look at that rigid stopwatch timeline versus the wild unpredictability of bringing life into the world, how much of our birthing process is truly a biological necessity, and how much is just our cultural preference?
A phenomenal question to end on.
Thank you so much for joining us on this deep dive. Keep questioning, keep learning, and we'll catch you on the next one.